Good afternoon. I'm Dr. Bouzis, and I hope to provide you some thought-provoking information here this afternoon. Let us begin by setting some expectations for the hour. First, this is not about the comorbidities associated with OSA. Secondly, this content and more has been provided on a web page specifically designed for this meeting that you can scan the barcode and/or I might have given you a card with the barcode and the password on the back. There are facts, and then there are just opinions. Most everything we hear these days are opinions, not facts. Most everything we see is a perspective, not truth. Facts can be proved. Opinions are just thoughts. So we need to be a little cautious about what we attest to. Next, my disclosures. I have no hidden agendas, no disclosures to make, and don't work for any appliance company or lab, magazine or publication, software company, or anyone other than just my patients. So I'm just like you, and what I am about to present here is just my opinion after the facts that I ask you to feel free to agree or disagree with, but please consider. So is sleep medicine hard or is it easy? I think the undisputed truth is that it depends. And it mostly depends on the reimbursement influence behavior, third parties. As Albert Einstein once said, if I had an hour to solve a problem and my life depended on it, I would use the first 55 minutes determining the proper questions to ask. So I think you need to ask yourself some questions. For those that have practiced sleep medicine more than 10 years, or 5 years, or 3 years, 2 years, or 1 year, how many would think that sleep medicine is easy? And how many would think the sleep medicine is hard? Can we first agree that in general, successful people do what unsuccessful people are simply not willing to do? First, a bit about what my path has been and where I'm coming from to where I am now. At 12 years old, a friend of mine and I worked for Monk Sullivan. If we were late to work, he sent us home. If we were leaning on our shovels, he sent us home. Oddly enough, on the following day, if we did make work, it seemed the prior day's work was already done. Looking back, perhaps he really didn't need us. But he was our Mr. Miyagi. We just didn't know it at the time. At 15 years old, I lied to a freight company so that I could drive a truck. I graduated the lower fifth of my high school class. I think I was in charge of entertainment. But I scored a 96th percentile on my ACTs. Needless to say, my initial college application was denied. I got accepted on probation after I got a Greek priest and also an alumni involved in it. They accepted me limited to 12 hours. I had to have a waiver signed by Fifth Army so that I could take ROTC, which was a funding issue for the school there at the time, for Creighton. And I ended up getting a 4.0 first semester, and oddly enough, they let me stay. So, who would have thought that I would be standing here before you, asking you to hear my message? Along the way, after I had children, and I already opened my practice, I had the opportunity to coach a Little League team in the Little League World Series. We had this gentleman, Harmon Killebrew, that was going to speak at the banquet. And I'll just never forget what he stood up and spoke just directly to the kids. He described that he had 8,147 at-bats. And he'd hit 573 home runs. But he had struck out 1,699 times. So Harmon had had exploratory surgery a couple of days before he was supposed to be in Casper. And we found out about that and called him up to see if he was still going to be able to attend. And of course he was, like, why are you asking me this? And during the autograph session, I asked him if he needed a break. We were in an industrial building. It was mid-July, 90 degrees out, no air conditioning, and he was struggling a little bit. So when I asked him that, he kind of leaned over and looked down this row of kids. There were still about 50 of them in line. And his response was, "These kids have a ball game to play tomorrow. Let's get them home to bed." So I think it truly can be said that successful people really do what unsuccessful people are not willing to do. And they really don't wish it was easier. They wish they were better. I kind of applied that unknowingly to myself. When I got out of dental school, the day I opened my practice, I traded one compulsive behavior for another. I quit smoking and took up fitness. I did that by starting to play racquetball, and eventually I got involved in tournament racquetball. It evolved into us putting a Pro-Am tournament on here in Casper, and just kind of went from there. So if you look at the upper left-hand corner here, this is Dave and Greg Peck, a couple of young men from El Paso, Texas, and we had them in for a clinic there in Casper. A friend of mine, we set it up and invited them in. There was probably 150 players that came to Casper and spent a couple days with these young men. And so they were from California, or from El Paso, I'm sorry, and they were in California doing a clinic there. They flew directly to Wyoming, and they arrived at 10 p.m. at night. And before we got to the turnstile to pick up the luggage, David asked me if there was a place they could go work out. And I kind of stumbled around and I said, well, not really, but I do have the backdoor key to the YMCA. They're racquetball courts. And he said, perfect. So the reason I had a backdoor key is me and my friend, we would go over there and set up a video camera when the YMCA was closed, and we would spend hours playing a 15-minute game and then come out and analyzing the video, just looking at court position and fundamentals, just really trying to get as good as we could get. So my friend and I, we got to sit and watch two professionals. At that time, they were both of them were in the top 5 in the country. And we get to watch two professionals work out for 2 hours trying to be good at their craft. During the 5-year tournaments we put on there, I got an opportunity to referee a few matches with Kane Wilsonchuk, a Canadian, who currently is a 14-time world champion. You know, what Kane has accomplished here is actually Tom Brady, but like on steroids. I mean, it's just an amazing thing. He has 10 more titles than any other pro racquetball player in history. I made a commitment to myself when I was playing racquetball that I was never, ever going to lose a match because of fitness. And I didn't. I lost matches for a variety of other reasons, and a lot of other reasons, but not fitness. So I hooked up with Covert Bailey, got weight underwater, subscribed to his teachings. Also, I subscribed to Ken Cooper's teachings with the Aerobics Research Institute, the Cooper Clinic. I believe that was in Texas. And Ken said that fitness is a journey, not a destination, that you must continue for the rest of your life. And I've tried to pretty much subscribe to that. So, I got out of dental school at about 25 years old, and at 30, I reached 25th in the country in my age group in racquetball. I got an opportunity to ski a little bit with Billy Kidd in Steamboat, and Billy taught me how to ski gates. He also taught me how to stand in a lift line. Let me tell you, I was a lot better at standing in a lift line than I was at skiing gates. In Colorado Powder, he offered lessons from a legend. And while standing in a lift line, he said, "That's not how Olympic skiers stand when they are waiting in lift lines," says Billy. "You don't win Olympic medal standing like that. You might get to keep the jacket, but you won't come home with a medal. Always stand with your poles apart. You have to look like a good skier. You don't want to look like a beginner." And similarly, as Dr. Drake says, fake it till you make it. One patient at a time, one physician at a time, one appliance at a time. So after a few years of tournament racquetball, I ended up with my first knee surgery. So I took up cycling, and my orthopedic surgeon told me I had to quit running because I would go out and run 5-6 miles and then play a couple hours of racquetball. What I was attempting to do there was obviously improve my fitness, but play when I was tired so that I could get used to fighting through that barrier late in a tiebreaker in a racquetball match. And as you might imagine, 200 miles a week, and 6 years later, I finished 8th at Nationals in Fort Smith, Arkansas, in the time trial. How did we do that? Well, similar to what I did in racquetball, I surrounded myself with professionals that did it well, and we did the same thing in cycling. So I rode a bike a little bit with Davis Finney, who was the Stage 3 winner of the 1986 Tour de France. Ben Edwards wrote about Davis. He said, "Finney had a special place in the heart of any kid that discovered bike racing in the 80s. He wasn't a superhuman aerobic freak like Greg LeMond. He wasn't a climber with the physique of a teenage girl with an eating disorder. Davis was relatable. Davis was cool. It was as if your high school football team's all-state quarterback decided to stop throwing touchdown passes and give bike racing a try. Davis had biceps. He had this I got this air about him when he walked in a room." So we put on a professional bike race there in Casper, and that lasted for 10 years. One of the racers that showed up there was Jonathan Bouzis. You see a picture of him here in the upper right-hand corner. This was when, in 2001, he got stung by a wasp when he was racing in the Tour de France. And because of the steroids they gave him for that, he got disqualified and couldn't continue the race. So Jonathan showed up in Casper, Wyoming, tour fit, wrote out a check for an entry fee, just like anybody else. And Jonathan Bouzis was a top finisher in the Casper Classic, and the best women raced there as well. For instance, the top 3 in 1994 were Evie Stevenson, Dee Dee Demet-Berry, and Allison Dunlap. And Allison was the 2001 winner, World Cross Country mountain bike champion. So again, we just surrounded ourselves with good people and tried to become as good as we could become. And I certainly subscribed to Lance Armstrong's theories of stop at nothing. Except, of course, the performance-enhancing drugs. I spent a little time with Andy Pruitt down at the Olympic Training Center, working on bike position, and essentially we were working on wattage versus heart rate and VO2 max. In a nutshell, we were trying to become as good as we could become and as fit as we could become with as little energy output as we could utilize in the process. Then at 62, I decided that I'd take up golf. And you might imagine these critters in the lower right-hand corner. There was many nights I would leave the golf course where it was me and these critters. And, sometimes if the weather was bad, I'd be the only one on the golf course. And again, all I was trying to do was become as good as I could become. After playing golf for a few years, I decided that I wanted to go to St. Andrews and play golf. So we did that, and you certainly can't play golf every day in Scotland. So I spent a little time at the National Museum there in Scotland. And of course, they had a bicycle section. This in the upper right-hand corner, this was Graham O'Bree's home-built, handmade bike from 1993 and 1994, where he won the world 1-hour record. I mean, that is very, very difficult to do. So kind of like the Fosbury Flop, he just set new standards with the time trial bikes. And right next to it, there was a Giant bicycle. That's the manufacturer. And lo and behold, that is the exact style of frame that I used when I finished 8th in Fort Smith, Arkansas. So as you can tell, I see everything, including dental sleep medicine, as an opportunity. And I've always tried to become as good as I can become, just like many of you. Fortunately or unfortunately, I kind of pass this on to my children. This is my daughter summiting in Iceland, a glacier in Iceland. And I think my compulsive behavior is sort of rubbed off on them, not intentionally. So my daughter's a physician, and when I got the opportunity to speak at this meeting, I reached out to her and asked her to recall, if she could, the just unreasonable excitation that she had when she called me one morning at 2 a.m. and she had just delivered her first baby. Her objective, her goal, her dream in medical school was to get out of school and set up a free clinic for children. So she had one vision in medical school, and now that she's been out for a decade or so, her feelings are much different. And I had her write that down for me, which she did. And after reading it, I called her up and I asked her, I said, would you please put that on a video for me? I think the group that I'm speaking to might find that rather interesting. And so this is my daughter, Ashley, on her take on medical care in this country.
Like most people, I went into medicine to help others. I completed much of my residency training at a level 1 trauma hospital. We were the receiving facility for 5 surrounding states and also for our local unhoused, underserved, and socioeconomically challenged residents. Upon completion of my residency, I took a job as an attending in that emergency room, and I quickly realized that I had been shielded from the frustrations of insurance during my time in training. Suddenly, in addition to triaging patients, providing them patient care and stabilizing them, and making the decision about whether or not to admit them to the hospital, I then had to get on the phone with an insurer and ask a non-clinical employee to agree to pay for that hospitalization that I was suggesting. It was not uncommon for these conversations to take as long as the actual patient care, and often the person on the other end of the phone could not understand that, sure, if Mr. X's diabetes was under poor control and Mr. X had a home to go to with a supportive care environment that was safe, Mr. X could go home. But Mr. X was an unhoused gentleman who slept in local shelters where his needles were frequently stolen. So no, Mr. X was not going to be able to improve his diabetes care in his currently available care environment. Mr. X was being asked to climb a difficult pitch with no equipment. I had a harness, I had belay equipment, and I had the skills to teach him how to summit. But the insurer's primary goal was to save money. And the way that they could do that was to deny my ability to hospitalize Mr. X so that he could gain the knowledge and be given the equipment needed to summit his difficult climb. Sometimes, though, I was successful at arguing my way past the admissions authorization, and then the insurer would place a limit on the number of days I could keep Mr. X in the hospital before he had to discharge. I could request additional days if needed, but longer admissions were frequently denied. At the end of his authorized number of days, I would take back his harness. I would send him out to navigate his climb again on his own. When Mr. X inevitably returned to the hospital in short course, the insurer would often refuse to pay for that hospitalization or only agree to pay at a reduced rate because we hadn't fixed his problem on our first go-around. Mr. X was a cog in the insurance wheel. He was suffering. We were frustrated. The insurance company was in complete control, and their CEOs were getting rich. Fun fact, Cigna's CEO, David Cordani, took home a cushy $19.7 million in 2020 alone. Now, well, I'd love to end this story with a heartwarming, oh, and then the insurance CEOs found their compassion, and we all worked together to get patients the care that they needed. The reality is, we're still all hiking up the icy trail of patient care. It's slippery. We aren't in charge most of the time. And the entity who should be our reliable belay, the insurance company, is busy lining their pockets while we all flounder on the rock face. I do think there's hope, but it will require strict regulation and removal of insurance lobbyists from policy influence. If we do not remove or regulate insurers' financial interest in patient care, we will all remain stranded on the rock face with the summit of wellness forever out of our reach.
So I think that kind of speaks for itself, and I've heard similar messages from the physicians I interface with. So for those that were able to attend the meeting, or for those watching this video, I'm not certain if you recognize where this picture was taken, but this is actually Mount Evans, and the Mount Evans hill climb is an iconic bicycle race taking place on the highest paved road in North America. It's an historical event that draws racers from all over the country to experience the challenge of racing from 7,000 feet up to 14,130 feet above sea level. As you might guess, I've spent quite a little time at my personal limits, as they say in sports, and I have 6 joint surgeries that are demonstrative of just that. I've done Mount Evans 5 times. At least 3 of those times it was snowing at the top, and you leave in spandex and no jacket from the bottom, and it's really quite a challenge. I asked myself why you would want her to go back, but we keep doing that. And so, as Nelson Mandela once said, it's all hard till you get it done. I would think one might guess. I've always been one willing to do whatever it takes. So what's the hardest thing I've ever done? Clearly, it's got to be sleep medicine. And that seems rather odd. We have good screeners. I'm not particularly saying that the Epworth Sleepiness Scale is one of those, but we have great screeners. We have the stop bang. We have neck circumference, adjusted neck circumference, the Lamberg screener, John Bibiano's Airway Awareness Screener, of course, DS3's digital screener. DS3 is also working on one, or they have it in the works. I think it's been kind of put on the back burner for a bit here, called Examinely, which I was been attempting to try to get that in medical offices. And also I'm working with a company called Rest Assured, that we're trying to get digital screeners via cell phone into dental offices, and it's kind of a challenge to get the healthcare professions to move forward with screening sleep. And testing devices. I mean, goodness, we have the Apnea Link, the WatchPat 1, the Gem Pro, the SatScreen, Nox T3, Metabytes, Virtuoxes, Z Machines, the Aries. Diagnostically, I do prefer the Nox T3. I don't particularly use that a lot because it's a little harder for patients to use. But I think we really have to admit that the real game changer, at least to oral appliance therapy, has been the Night Owl. It allows us to really fine-tune and calibrate our appliances in a manner that we really didn't have available to us before. So, regardless of what screener you use and regardless of which testing device you use, just pick one. Of course, they all have different advantages and disadvantages, but just start somewhere. Just pick one and start screening and diagnosing your patients. There's certainly been some hiccups along the way. Being a provider for both ResMed products and Respironics products, I'm a little bit kept up to date a bit on the Philips recall. And obviously ResMed has not been able to meet that need because of supply chip problems out of China. So we just have a whole wide group of patients out there that are just floundering around on the rock face, as my daughter would say. And they don't know where to go, how to get treated, and most of them don't want to get treated anyway because there's not very much awareness that they have that they should. And there's then the AHRQ report. That's the Agency for Healthcare Research and Quality, the U.S. Department of Health and Human Services. It reported that studies fail to show long-term benefits from CPAP. And this was just April 9th, 2021. The studies were highly inconsistent in how they define breathing measures, such as AHI and ODI, and by extension, how they define OSA, even though they followed standard PSG criteria. The reporting of a specific diagnosis and PSG criteria were generally poor. In this 155-page report, no significant effects were found as a result of CPAP on long-term clinical outcomes for adult OSA patients. I provided that report on the web page that I've created for this meeting, and there is some highlighted areas in there, so for those of you that don't want to read the entire report, you can just skip through and look at the highlighted areas, and it'll give you kind of an overview of what that report was about. I think most, if not all, of these reviewed studies allowed 4 hours per night, 7 out of 10 nights adherence criteria to be used. And the reality of it is, for me, when you're trying to evaluate a device, how can you possibly properly evaluate that device with those pathetic adherence criteria? So they're going to relook at that, and we'll see where that goes. But I think before we dentists start doing the happy dance, we might be careful, or along the way with CPAP, we might find ourselves sitting on the sidelines, as they say, and the payers are likely to look at this stuff because they're looking for any reason to not pay, as they use terms like medical necessity. Speaking of healthcare, on the webpage I have placed some reads, maybe a dozen, 10 to 12 books that I found very, very useful that are about healthcare in this nation. One of them, Healthcare is Killing Us. An excerpt from that is, everyone in healthcare will tell you that the fundamental underlying belief is that patients come first. Rather, we question if the underlying belief isn't instead actually that we need to say that the patient comes first, while there is really very little we actually do that reflects that. The first thing many receptionists ask upon arrival is insurance. They may even do that before they say hello. Very little in our present system actually supports the premise that patients come first. On January 7th, 2022, just this year, a physician, surgeon, contacted me requesting a mandibular advancement device. And while we were discussing his options, I expressed that I was slowly reaching the acceptance stage regarding our healthcare system, after which he told me he was at the hopelessness stage. Imagine having a career where you go to work every day and you just can't do what you know you are capable of for the patients coming to you for care. Jason Tierney posted on LinkedIn, the sleep medicine system is broken, from screening and diagnostics to provider communication and diversity of treatment modalities. Broken. This 2-minute video with Barbara Phillips, MD, succinctly sounds the state of emergency warnings. This isn't medicine's issue or a dental issue. It is a human issue. I'm certain many of you have already watched this video, but I think in the context of the message I'm going to try to deliver here, I think it's important to rewatch this again.
Probably, depending on how it's defined, about 10% of the American population has obstructive sleep apnea. This is a risk factor for hypertension, stroke, death, atrial fibrillation, car crash, and a lot of things that can affect not just the person who has it, but their bed partner or the person in the shotgun seat or oncoming lane. So it actually is a public health problem of some magnitude. The diagnosis and management of sleep apnea to this point has been, in my view, too complicated, too time-consuming, too expensive, too patient-unfriendly, too test-oriented, and not nearly enough follow-up chronic management-oriented. That is changing. It has to change. There is a professional organization that continues to insist that physicians who are board certified in sleep medicine be reimbursed for reading the sleep studies, which is where the money has traditionally been, and which I can tell you is not rocket science. The management, actually, the follow-up, the actual care of the patients has just been sort of willy-nilly, slipshod, not necessarily done by people who even understand what a sleep study means. As a result, the vast majority of people with sleep apnea remain undiagnosed. They don't want to bother with all this expensive testing, or maybe they have the test but they never even get any follow-up. And many people who are prescribed effective treatment don't use it, again because chronic use of any treatment requires ongoing encouragement, education, follow-up adjustment, and care, which has really not been a huge focus of professional organizations, which seem to be a little bit more focused on testing than on actually taking care of patients.
So I think that somewhat speaks for itself, but what I'm going to ask you to ask yourself, what professional organization would you guess Barbara Phillips is actually referring to? More on that later. Some responses to Jason's post. Roger Price. Jason, I've been using this 2-minute clip for the past 3 years in my teaching, but it sadly falls on deaf ears most of the time. I have discussed this with Barbara Phillips, as well as with other high-profile sleep physicians, and privately they agree the system just doesn't work. John Viviano. Dr. Phillips has summed up both what is wrong and what needs to change in this short clip. The most valuable contribution I make to my patient's care happens after the initial diagnosis and me fashioning and providing an oral appliance. It's all about continual follow-up. How can it not be? We are talking about a chronic illness that continually changes. Bob Stanton. Yes, it's all about continual follow-up, whether it's oral appliance therapy or PAP therapy. I do PAP follow-ups for patients that often started in a dental practice, but after testing, the agreed-on treatment plan was PAP, often due to the severity of the OSA or other medical issues. These compliance follow-ups and supply calls are important. Rob Sutter. Amen. The challenge is there is no money in the initial CPAP therapy, only in long-term resupply for the DME providers. So they are getting paid a lot less to manage you longer into the trailing revenue area where they are profitable per patient. When Medicare is only reimbursing $300 and $100 for a mask for a $200 PAP and a $50 mask, your gross margin is $150, minus your CPAP text time, $25 an hour, for proper setup done in an hour with travel, $125 per patient, maybe. Hard to give great care and drive high compliance in that environment. Bob Stanton. One approach, do the PAP resupply and set up via telemedicine. Obviously, COVID's opened that door, and certainly that saves some time, but it doesn't make it much easier, really, for the DMEs. Another suggestion is to integrate DME into follow-up medical care. And actually, I'm working with a local hospital, Banner Health, to see if we can't get sleep questions asked at every routine visit with primary carers. They told me they can do that, but that was near a year ago and it still hasn't happened. Bob Stanton again. Agree with Rob. The insurance requirements drive treatment rather than good medicine. Patient not compliant on CPAP wanting to restart as they were not compliant during the last 30 to 90 days. Just stupid. The $200 or so to get a patient back on PAP could save insurance much more in cost from having to treat the comorbidities. So many people refer to sleep medicine as being broken. I'm not sure that I'm a believer in that. My belief is that our system is not particularly broken, but it rather functions exactly as it is designed to do. And then, out of nowhere, it appeared that the American Academy of Sleep Medicine was admitting to OSA being epidemic, and they were requesting help. The processes, according to them, needed to be disrupted. I said, just count me in. 2-day meeting, March 12th through the 13th, which I attended. Look at all these positions I was going to get a chance to interface with. Remember Dennis Hang. Also, remember Bouzis Sex's, of course, chair. We must reimagine sleep care. And change starts with you and every one of us. But there was a bonus. Challenge. Contest. We could become change agents. An Ideathon. A 6-week contest from April to May 20th. We can make a difference. First, a short excerpt from the Sleep Medicine Disruptors 2021 March 12th to 13th meeting. This is Dennis Hang, MD. And he spoke a couple times there. This is just a very short excerpt from this. This entire video, I think, is available on the AASM site. I think you have to pay to get that, but it's too large for me to put on the website, so I couldn't make that available. But here's what Dennis said.
In both of these patients, just simply severe obstructive sleep apnea. A third example, same patient, what's it different? AHI went from 102 down to 2. You may be surprised, for me to tell you that we treated this patient with an oral appliance, which I think in some circles might be considered to be malpractice. And this is a patient who had terrible aerophagia with, CPAP, and we noticed, on his sleep study that, most of his events were hypopneas. It was a patient who probably has a very low arousal threshold. Probably doesn't much to open up his airway, and sure enough, we put him on an oral appliance and his sleep apnea essentially resolved. So this highlights what the data is telling us is problem number one, and it's really how we define obstructive sleep apnea, define OSA severity, and it influences the way that we manage patients.
So certainly the way we define OSA has been also questioned by the previously mentioned AHRQ report. But I think, first of all, we're going to hear more from Dennis later, but I think particularly it's interesting to me is how can we properly treating a patient be thought of as anywhere close to malpractice? And yet I know exactly what he's saying. Imagine the back and forth and the wrestling match that would have to take place to get this patient oral appliance therapy with an AHI of 102. And you're going to be fighting with physicians, with insurance carriers, and lo and behold, if you do get success, nobody's going to pay much attention to it or care very much about it except you and the patient. So, a team was assembled. We only had 6 weeks. With 20 to 24% of adults suffering with OSA, with children being mostly ignored, and dentists perhaps being the collaborative army. As Kevin Costner said in Tin Cup, I felt this was a lock. This is an excerpt from our presentation to the AASM Disruptors, where we presented a 15-minute video along with a 6,000-word proposal. Myself, Jay Crisandi, Dr. Husseino, our local sleep physician, and of course, John Viviano helped me in this process. I really thank John for the work that he did and putting some of the video together and the way he expressed himself during this. It was really kind of him to help me with this.
Welcome to Sleep Medicine Disruptors, a medical dental collaboration. It's time to invite dentistry to the table. Our team leader, Dr. John Bouzis, is a practice limited to sleep medicine, providing both oral appliance therapy and PAP by physician prescription only. Dr. Jay Crisandi also always works under the prescription of a physician, has treated over 5,000 sleep patients in the last 5 years with both PAP and oral appliance therapy. Dr. Mohammed Amar Husiano is a pulmonary disease specialist boarded in sleep medicine, and myself, Dr. John Viviano, is a clinic in Ontario, Canada that provides conservative therapy for sleep-disordered breathing by way of oral appliance therapy. I'd like to start off the presentation by presenting excerpts from the Sleep Innovation podcast where Dr. Seema Koshla interviewed Dr. Azizi Sexas.
We are going to take care of the people that we serve. It's one of the most sacrosanct virtues and values of being in this field. We want to start to build a coalition and a community of people to do this type of work.
Well, let's take a look at the current status of sleep-disordered breathing. Approximately 90% of the adult population remains undiagnosed, and children are mostly ignored. 90% of those adult patients that are diagnosed are prescribed positive airway pressure, of which 50% remain compliant at 6 months and 17% remain compliant at 5 years. Dr. Koshla expressed some serious concern.
So help me with this. I feel like we are all overworked and that we are perpetually in survival mode.
And Dr. Sexas shared his vision as to the solution.
We got to reimagine healthcare in terms of education, in terms of clinical care, in terms of research, in terms of venture, meaning our relationship with the private sector. And lastly, we need to reimagine how healthcare provides outreach and service to the community. In order for us to do this, we need an entire arm.
What about dentistry? 80% of Americans have dental benefits, and 79% of Americans visit a dentist every 2 to 3 years. In Canada, 80% of Canadians have a dentist, and 86% visit their dentist every 2 years. Patients are accustomed to attending for regular dental follow-up visits. Dentistry provides direct professional access to patients with the ability to screen, offer therapy, and follow-up resources. Active screening of each patient of record would reduce undiagnosed levels dramatically, helping to set the patient on their path to wellness, whether it be through behavioral modification, positive airway pressure, or oral appliance therapy.
When we see that there aren't enough sleep clinics out there to serve the great need that we have in the community, we need to turn everything on its head and just say, how do we reach these individuals? Develop new solutions, not just technology solutions, but solutions of care and workflow so that we can better reach people. And that is the key.
New solutions of care and workflow. So we have to think differently than we have been thinking over the last 30 or 40 years. AADSM, respected evidence-based organization. Oral appliance therapy, respected high success rate conservative therapy. An MD-DDS collaboration provides PAP non-adherent patients easy access to oral appliance therapy with similar health outcomes to positive airway pressure. There are many benefits of an MD-DDS collaboration. They include mobilizing the entire dental workforce, which can provide screening, referral, oral appliance therapy when appropriate by physician prescription, and follow-up. But is dentistry and oral appliance therapy worthy? Well, clearly a single treatment offering is not working and has led to polarized clinicians.
So I think it is clear that we have polarized clinicians. We have a this or that form of therapy rather than whatever therapy works. We have a tendency to look at who's doing what rather than look at who's doing what well. And patients have been moved down the list as far as priorities. They're basically treated as pawns or commodities that if you can do something on them, maybe not for them, then you can bill an insurance company. And you know, our system really just doesn't work very well. This is the results of the 2021 Disruptors Ideathon contest. And although the results were actually in within about 6 weeks, a little bit longer than that, this was presented again by John Viviano, and this is a very short excerpt. And I've tried to provide almost all of this in full content on this webpage where I could, so that way you can make sure that I haven't taken anything out of context here, and you can go through the entire content and then make your own decisions. But anyway, here's John again.
The current model for identifying, diagnosing, and treating sleep disordered breathing is simply broken. It's a bold statement, but nevertheless true. ASM recently sponsored a Sleep Medicine Disruptors 2021 contest. The purpose of the contest was to stimulate fresh thinking and encourage dialogue. Okay? About 25 teams entered. There was global participation from around the world. There was a couple lucky winners. They got a prize, they posted a video, and the presentation was all posted online. There was 5 other teams acknowledged, and their videos were posted online. What came of the losers? Could it be that the remaining 18 teams provided absolutely nothing worthy of discussion? Our submission, the medical dental collaboration, was one of the losing teams. This was their position. Out of respect for judges' time, submissions were selectively passed on to them for review. So, the organizers screened the submissions and decided which the judges were going to judge. The topic MD-DDS collaboration was censored out of the running and was never even viewed by a judge. So much for stimulating fresh thinking and encouraging dialogue. This is a little excerpt from a podcast called Sleep Innovation. The chairperson of the Sleep Disruptors Contest, Dr. Assisi Sexas, was interviewed by Dr. Seema Khoshla. And Dr. Seema Khoshla stated, "I feel like we're all overworked and perpetually in survival mode." And Dr. Sexas, the chairperson of the Sleep Disruptors Contest, answered in this way.
We got to reimagine healthcare in terms of education, in terms of clinical care, in terms of research, in terms of venture, meaning our relationship with the private sector. And lastly, we need to reimagine how healthcare provides outreach and service to the community. In order for us to do this, we need an entire arm.
So Dr. Sexas is acknowledging that they need a larger workforce. The number of people they have engaged in play can't even begin to take care of the massive problem. So that's understood. And then we have this army of dentists approaching them about, hey, let's work collaboratively. And their submissions isn't even viewed by the judges as being worthy, because out of respect of the judge's time. So, a recent article, Board of Directors of the ASM stated the future of sleep medicine lies in its ability to provide the workforce to care for sleep disorders across the population from cradle to grave. So they're looking for an appropriate workforce, discussing leveraging this technology such as telemedicine, smartphone apps for patient monitoring to improve efficiency, increase satisfaction, and reduce costs. Now, technological advances have surfaced with acceleration during COVID. We know telemedicine has become a standard at this point. COVID-19 and other current events that we'll be discussing may also be accelerating acceptance of oral appliance therapy.
So that was the results of the contest, and what I'm going to show you now is an excerpt from the podcast, Season 3, Episode 15. And before I do that, both of these podcasts, amongst many, many others, are available on the AASM website. These two are available on the webpage that I created for this meeting, and you can watch those again in their entirety, so then you can make your own judgment as to how you want to interpret those, and you don't have to just blindly accept mine based upon a short little excerpt that I've provided here. So Season 3, Episode 15, describes how sleep depth could impact CPAP adherence. The AASM's inaugural Change Agents competition brought together teams from all areas of sleep medicine to think about innovative and creative ways to reimagine the diagnosis and treatment of obstructive sleep apnea. In today's episode, we talk to the leader of the winning team, Dr. Amy Bender, about their proposal, Let's Put the Sleep Back into Sleep Medicine, which recommends measuring sleep depth to predict CPAP adherence and offer more personalized sleep apnea treatment. So here's a brief section from that podcast.
Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. This episode of Talking Sleep is brought to you in part by Avadel Pharmaceuticals. The content of this episode was independently developed by the American Academy of Sleep Medicine. Earlier this year, I had the opportunity to participate in the AASM's first ever Change Agents competition. This was a program designed to look at treating obstructive sleep apnea in new and innovative ways. I'm really proud to say that my team came in second place, but today we're going to talk to the leader of the first place team, Dr. Amy Bender. Dr. Bender is the Director of Clinical Sleep Science at Cerebra Health, a medical device technology company that is working to change the future of sleep healthcare. She joins us today from Winnipeg, Manitoba, Canada.
So this submission, in my mind, was clearly more than worthy of being the winner, and has been made available on the web page that I associated with this presentation for your review. So that is their presentation, their 15-minute video, along with the 6,000 word proposal. That is all available on my webpage for you to look at, so that then you can make your own decisions on that. So this is just an opinion of mine. To me, there is clearly a group of patients, perhaps a larger one than we might think, that by current standards have their OSA treated, in that the AHI and SpO2 values have been normalized, but the therapy itself, PAP, is fragmenting their sleep. This could be an explanation as to why we often get patients reporting that they are doing great with oral appliance therapy, while by current standards, the AHI is higher than we would like to see, and the sleep industry then in turn labels the mandibular advancement device as a failure. If indeed the odds ratio product can identify those patients likely to fail PAP by tracking sleep depth as needing alternative therapy, it just might open the door for oral appliance therapy even more so than the Philips recall and the AHRQ report already have. But dentistry needs to be humble in the process. But let's think about this a moment. So you have the Sleep Medicine Disruptors March 12th to the 13th 2-day meeting. You have the Sleep Medicine Disruptors Change Agents Ideathon, a 6-week contest. You have Dr. Seema Khosla, who is the medical director for North Dakota Center for Sleep in Fargo. You've heard excerpts from the AASM podcast, Season 3, Episode 9, where Dr. Seema Khosla interviews the chair of the Disruptors Contest, Dr. Azizi Sexas. Now, she herself is a participant in the contest. Submissions are censored for the judges. She and her team win second place in a contest where participants, again, were censored from the judges. Then she in turn interviews the first place winner, Dr. Amy Bender, in podcast Season 3, Episode 15, which was sponsored by Avidal Pharmaceutical Company, the content of which was independently developed by the American Academy of Sleep Medicine. So I'm not saying you should think this way, but there's some things that just make me go, So I'll let you be the judge of that. But I think we can safely say that you really can't read the label from inside the jar. You need some help from the outside. So this is another short excerpt from one of the meetings from where Dr. Hang, Dr. Viviano make comments. This is July 29th, and this meeting has been made available on the webpage as well. So I'm going to play this for you here, and I think you'll find this kind of interesting.
Thanks, Rick. 2-minute warning. So 30 seconds for Dennis and 30 seconds for Viviana.
All right, quickly. Yes, fully agree with Dr. Bogan. Incorporating dentists is very valuable. Quick answer to the multidisciplinary model. Agree with Dr. Strollo. Conceptually, yes. And in fact, we've incorporated a behavioral sleep medicine team. We're in close collaboration with pulmonary, peds pulmonary, inpatient pediatrics, all patients who, little babies who are sick, they get transferred to our NICU and we study them. And all these teams know to directly contact my case managers rather than the physicians. So it's very much a team effort with multiple disciplines. And the one-stop shop model, I think, creates both a better patient experience as well as a provider experience because they both know where the hub is. However, multidisciplinary encounters, no, I don't think that works. For pulmonary hypertension and ALS that was mentioned, you can do that because of low prevalence and high intensity of disease. But the prevalence of OSA is just way too high, for this to be cost effective. And in fact, I think we're on the other end of the spectrum where we're using case managers as extenders, physician extenders, to try to increase the volume of patients that we can care for.
Thanks, Dennis. Dr. Viviano, go ahead.
Love the discussion on the multidisciplinary approach, and I know of a number of centers around North America that have pulled it off and do very well with it. Just like to suggest that there's something else that we'd like to bring to the table here in the discussion, at least thinking. A better collaboration between physicians and dentists would open up so much more care to patients. And Alberta, Canada actually has that in place with guidelines that were written by all the stakeholders, the physicians and the dentists and so forth, the associations. And so we have the dentists there on the front lines, owning sleep testing equipment, dispensing it, reporting, doing all the proper evaluation like they've been trained to do, and then reporting and working with a board-certified sleep specialist that's making decisions and so forth, and then working collaboratively together. So they're not in the same office, but it really is a multidisciplinary approach, and they are a model as to how this can be done, but it requires some changes.
Thank you. Those are great comments, and I really appreciate the also the multinational perspective on this. So we are at the top of the hour, or not top of the hour, we are at 9:30, we are at the end of our webinar. I just wanted to give a huge thanks to our panelists for taking time away from their busy schedules for this very lively live.
Can I make one comment based on what Don just said? Because I think there's, if we're going to talk about the success of oral appliance, moving into the future, I think there's one thing that we haven't discussed that's kind of the elephant in the room that probably needs to be put out there, which is there's a lot of distrust between the sleep physicians and the dentist, right? The dentists feel like the sleep physicians, don't believe in their product and are just trying to make a lot of money, and they're trying to do things that are outside their scope, right? And And that's, how many sleep physicians, feel. So, for oral appliance, I think to become successful, we're going to have to bridge that gap some way, and the way to bridge that, I think, is a much larger discussion that we're not going to be able to do in the next 30 seconds. But I think if we're going to be successful with this, that's an issue that's going to have to be addressed.
Agreed.
Yeah.
So I find this kind of interesting because you'll note that although Dennis is very cautious about what he says, and on both of the little excerpts I showed you here, he really hasn't spoke up until right at the end of a presentation. But when he does speak up, he can't help himself because what he says speaks for and is fully in the patient's best interest. I'm not sure our medical system does that, but Dennis certainly isn't. Obviously, so is John Viviano. As far as a multidisciplinary care model from near a decade ago, in the Journal of Clinical Sleep Medicine, Volume 9, 2013, there was a proposal in there about sleep medicine care under one roof and consolidating the care towards better results for patients. This, again, is also provided on the webpage. Many of you have probably already read this. But we seem to spend more time talking about things that need to be done rather than actually implementing them and getting them done. If we just spent the energy actually putting things in place and then tweaking them as we went along, why, I think patients in our practices would be far better off. But you think it would be maybe safe to say that sometimes doesn't it feel as if treating sleep medicine can be a little like building an airplane while trying to fly it? Or maybe even like herding cats.
Herding cats. Don't let anybody tell you it's easy.
Anybody can herd cattle. Holding together 10,000 half-wild short hairs, well, that's another thing altogether.
Being a cat herder is probably about the toughest thing I think I've ever done.
So, I don't happen to be one that believes that we can win a dental medical battle, even if it is justifiably in the patient's best interest, because the referee will always be the unregulated payers. This is a medical problem with sometimes a dental solution, demanding dental medical collaborations. Our patients need us to need each other because no one form of therapy treats all patients. As General George S. Patton reportedly said, "Don't tell people what to do, but rather describe what needs to be done, as it empowers their own ideas." He also reportedly said, "No good decisions are made from a swivel chair." So change starts with you. It starts with all of us. I ask you to define your own success. Much like Harmon Killebrew, I've hit some home runs. However, I've mostly struck out. But I've chosen to stay in the game. Again, I ask you to define your own success. One patient at a time. One appliance at a time. One physician at a time. Without a doubt, you must first learn your craft. But then don't question what you do or who you are, but rather question our healthcare delivery system. Stand up for patients. And then find a way to support, interact with, and yes, even educate if you must, the medical team as patients need us to work together in their behalf. I think it's also important when you're finding your way, what really counts is how you approach the problem. If you really want to do something, you will most definitely find a way. If you don't, you'll just find an excuse. The landscape in dental sleep medicine and sleep medicine, it needs to change, and it definitely does start with each of us. Feel free to reach out to me if you have any questions or comments. I'd be more than happy to entertain them. You can catch me during the meeting or email me or somehow reach out. The barcode here will gain access to the web page, but if you're watching this video, you already have access to that. I don't have a problem with you passing that on to whoever you want to pass it on to in the healthcare field. I think that if we can form a group that is patient advocates, then perhaps we can make a bigger difference than what we're making now. As I said at the meeting, I hope you all enjoyed the meeting, and I hope that, if nothing else, my presentation has provoked some thought and perhaps some action in some little corner of the world.